Hi there, my name is Emily and I am presenting this video today to share with you about the breastfeeding challenge of engorgement with the comorbidity of feeding twins as a part of my BCIT NSPN 7155 Breastfeeding Theory Experience. To discuss the topic of engorgement in twins, I will be using the Gillespie and Peterson Situated Clinical Decision-Making Framework. It has 5 stages, and they are building knowledge, recognizing cues, using clinical judgment, making decisions, and the evaluation of care. I want to begin this talk by reminding you about the 3 rules of breastfeeding. They are feed the infant, move the milk, and help the dyad. So let's get started. What is engorgement? Breast engorgement is when a mother's breasts are painfully overfilled with milk. This is caused by the mother overproducing milk during the initiation of breastfeeding or soon after as milk production increases. This means that engorgement can occur anytime there is an increased supply of milk in the breast. This is a breastfeeding challenge because severe engorgement can be extremely painful, and when poorly managed can lead to the destruction of breast tissue, loss of milk supply, and breastfeeding failure. It is an urgent situation and requires prompt and effective management. So let's explore this a little deeper. A baby is born and placed on the chest of a mother. The placenta is then delivered, decreasing the levels of estrogen and progesterone in the mother's body. Prolactin is released from the anterior pituitary. Simultaneously, oxytocin is secreted from the posterior pituitary. Breasts will begin to feel fuller as the milk glands fill and the breasts have increased blood flow, and fluid gathers in the tissues. Then the infant is not effective in emptying the breast, which leads to milk volume excess that exceeds the alveolar storage capacity of the breast. Then where does all that fluid go? It obstructs capillaries and ducts, causing the leaking fluid to move into the surrounding tissues, causing swelling. We know this as breast engorgement. Some of the causes and risk factors of breast engorgement are separation of the mother and infant. This can be big for twins as they spend time in the NICU. Impeded milk flow, which can be something like breast augmentation or as simple as a restrictive bra. An abrupt decrease in feeding, or when the diet begins to wean or solids are introduced to the diet. Small or restricted feedings, ineffective feedings, so this can be caused by poor latch, impaired mechanics like a tongue tie or flat nipples, or breastfeeding with a premature infant. This is a big one for this presentation because many twin pregnancies are born prematurely, so before 37 weeks gestation. And lastly, smaller breasts. I know what you might be thinking. That woman has small breasts, so there's no way she would get engorged. Well, I kid you not, a woman with smaller breasts actually has an increased risk of experiencing engorgement while breastfeeding. Let me explain this a little further. Because this smaller breasted woman is not able to hold as much milk at one time as a woman with larger breasts, there is more milk to produce and move out of the breast of the baby, increasing the risk for milk volume excess. Now that you have a better understanding of what breast engorgement is and why it can happen, let's move on to some cues or signs and symptoms of breast engorgement. You might find a woman's breast who is engorged to be painful and tender, full or swollen, have skin that is tight and shiny and often red. Think of the skin of a red delicious apple. Have a sensitive sore nipples, or have difficulty latching their infant when they didn't before. Or a woman who is experiencing breast engorgement may also have a low-grade fever. So let's talk about some clinical judgments as we move into another step of the decision-making framework. As a nurse or healthcare provider, you need to make an assessment of what is happening, and it might sound a little something like this. I understand that breast engorgement is an imbalance between supply and demand. I need to look at each dyad within their own context and assess the factors that have led to this breastfeeding challenge and create a focused intervention through education to support them. Nursing assessments can include mother-infant positioning, assessing the effectiveness of the latch, length of separation of mothers and babies, and the actual prematurity of the feeding infant. Once the challenge is found, steps can be taken to create opportunities for consultation. This can be as simple as on-the-spot education at the bedside, but it can also include referrals to lactation consultants, public health nurses, or breastfeeding clinics, and their physician. Under this topic, I really want to highlight how crucially important it is to assess mother-infant positioning when it comes to dealing with twins. First off, mothers need to decide if they're going to breastfeed their babies together or separately. The big push to breastfeed twins together is that it can be a huge time saver. If the mother has decided to feed the babies at the same time, she may need some initial assistance positioning and latching the babies, and some women may even wish to purchase a breastfeeding pillow made specifically for breastfeeding twins, as it can enhance the breastfeeding experience of the triad. There are many ways to hold babies while breastfeeding, but a couple twin-specific breastfeeding positions are the double football, where each baby is placed on the pillow beside the body with its legs to the back of the chair, the cradle-clutch combination, where one baby is cradled and its body is facing the mother, and the other baby is on top of or beside its sibling in a clutched hold. The stronger sibling should be in the cradle position. The double cradle hold. This is when both babies are in the cradle position with their legs overlapped, making an X shape. This can be performed in many different ways, so that women should try different variations to decide which is the most comfortable for the three of them. Now, do you remember those 3 breastfeeding rules I mentioned at the beginning of the video? Good. But just in case you need a reminder, they are: 1. Feed the baby. Increase the frequency and duration of feeds. Improve latch. And if needed, use appropriate supplementation. We just want that baby to eat. 2. Move the milk. To facilitate milk movement, we can do everything I just said to feed the baby, but also support the mother to use hand expression or a pump to stimulate production and move the milk out of her breast. And 3, help the dyad, and in this case, triad. Support the mother in her breastfeeding efforts and provide some suggestions and teaching, like working on her latch, trying a different position, and watching for her baby's cues. Now, those were the 3 rules of breastfeeding, but I'm going to share with you what my 3 priorities of care would be for a mother who is breastfeeding experiencing engorgement. I would first address the woman's pain. Even if it cannot be treated in the moment, show empathy and compassion in your care. Number 2, I would ask the woman what she wants from me first, or at least assess it. Does she need me to listen, teach, act, or refer? And then number 3, and I think this one's really big, know your resources. Be aware of supports in the community, as you might only see this woman for 1 hour in her journey of breastfeeding. If you have resources that you can provide to have the women have support for a longer duration, share it. Nursing is a team profession, and we're stronger when we work together. Okay, that's a lot, right? Not much longer to go. Let's talk about decision making. What is the most optimal nursing intervention? That's right, prevention. And this goes back to our 3 rules of breastfeeding. But here are some more specific steps I can recommend women take to prevent breast engorgement while breastfeeding. Breastfeed often, ensure that you have an effective latch in position, move the milk, wear a non-constrictive bra, and make sure the woman has support. Now, in the event that breast engorgement does occur, it does need to be treated. As I said before, it is a breastfeeding challenge and can turn into an emergency. Every woman is individual and needs to be treated so a variety of things can work. They include frequent feedings, hand or pump expression, cool compresses, chilled raw cabbage leaves, short-term moist heat like a shower, and inflammatory medications like ibuprofen. Now for the last step in our decision-making framework, and I think the most important, evaluation of outcomes. You might find this section closely relates to the 3 priorities I shared when caring for a woman experiencing breast engorgement. We need to explore how effective our judgments and decisions are when helping this woman. This can be done through asking yourself questions like, is the mother growing in confidence? Is she getting more comfortable positioning and latching her infants? Is she experiencing less discomfort from her engorged breast? Are the infants receiving adequate nutrition? And is the mother expressing a desire to continue on with breastfeeding? With this assessment, we will be able to evaluate the progress of our efforts to support women in their breastfeeding journey, even when they come up against challenge. So I think that's about it. So to summarize, engorgement is the imbalance between supply and demand. We want to prevent it rather than treat it, so remember your 3 rules of breastfeeding. Feed the infant, move the milk, and help the dyad. And in general, be kind and empathetic in your care. Know your resources and always be open to adapting your practice to meet the needs of your patient. Thank you so much for taking the time to watch this video, and all the best in whatever your breastfeeding journey looks like.